My name is Basma. I'm one of the cardiology residents. I'm doing echo right now, and I'm going to present the pulmonary vein Doppler. I called it the unraveling the mystery because this is how I felt about it until today, and hopefully by the end of it, you guys will feel the same. Okay, so these are my objectives. So before we talk about the objectives, actually, most of my talk is from this review article by Fadl from 2021. It's a great article. I really recommend people reading it. So these are my objectives. First thing, I'll talk about the anatomy and some variation in the pulmonary vein anatomy. I'll talk about the function and physiology of the pulmonary veins, and as well as some pathologies and how they affect the Doppler waveform. A little bit of background for Dr. Chow specifically. He likes history, so it wasn't until 1980s when Doppler PW was used to assess the pulmonary veins. Prior to that, they were all done by invasive methods with cath, and I found this article that is from 1985, and it's a good one, and it has some. It talks about the flow vein pattern and the Doppler waveforms. Okay, so first thing, anatomy. Whenever somebody says pulmonary veins, this is the picture that comes to my mind. So you have 4 pulmonary veins, and this is accurate for about 70% of people. So you have 2 right upper pulmonary vein on this side, right lower, left upper, and left lower. The ones on the right side, as you can see, they run behind the SVC and behind the right atrium. The ones on the left side run in front of the descending aorta. And the way they enter the atrium, the ones on the right side, they enter on the posterior aspect, close to the intra-atrial septum, and the ones on the left side, they enter into the lateral wall of the left atrium. So this article shows you different variation of pulmonary vein Doppler with pulmonary veins anatomy. It's a paper that looked into people who had underwent AFib ablation, and they found different morphologies. So some people had a common trunk, which can be short or long, and other people had even extra pulmonary veins in different areas and locations. But obviously, this is by no means all the types and variations. This is just what they found in this trial, in this study. Okay, function. So pulmonary veins are thin-walled structures. They work as conduit to maintain the left side stroke volume and the output, despite beat-to-beat variation in the RV stroke volume. As you can see, they're connected on both sides. So on the left, on this side, they're connected all the way to the RV. So the RV into the pulmonary trunks, into the lungs and capillaries, and then into the pulmonary vein. So as one can imagine, anything along the line or the pathway, if you have any changes, anything that affect the pathway can result in different morphologies in the pulmonary wave Doppler waveform. And then the left side, same thing here. So they're connected to the left atrium and the left ventricle. So changes in the ventricle or stiff atrium, for example, will give you variation in the waveforms. So I put here a question mark for respiratory phases. So does respiration affect the pulmonary vein waveform or not? So they do, but to a very minimum degree. Overall, they don't really have much influence on the waveforms you get. All right. Before going into the physiology, I wanted to mention the left atrial functional phases. And I wanted to show you that in relation to the ECG. So the first function is it works as a booster pump. So it gives you the atrial kick, which is like the 20% of the output from the left atrium, and the reservoir phase is when it stores blood, and conduit is where you get the early emptying of the atrium. And in relation to the pulmonary vein, the A wave, so there are 4 waves, and I'll talk in depth later on, but in general, there are four waves. So there's an A wave, S1, S2, and D wave. The A wave happens after the P wave, after the atrial kick. And then the S1 and S2, these are systolic events, so they happen during systole. And then the D wave is a diastolic event, so it happens during diastole. Okay. So how, in terms of echo acquisition, where do you find them, how to get them? if you're scanning a pediatric person, you get them all from the suprasternal angle. This looks like something, I don't know if you can see it, but it has a special name.
Crab.
Sorry.
Crab.
Yeah. So this looks like a crab. They call it the crab uses the body, eyes, and arms and legs. And I tried to put a picture for you. It looks like okay, that's not the case, unfortunately, in adults. So you have to look, you have to maneuver and have to look into different views and tilting and rotations. So if you're trying to get the right upper pulmonary vein, and it's the same for the left upper pulmonary vein, you go to the apical 4, and then you do a little bit of anterior angulation. So you're trying to get into apical 4, but not really, apical 5, sorry, but not really. So partial apical 5, you can call it. And then you'll be able to get those two veins specifically. The right lower, you go into apical 5, but for this one, you go posterior. So you do posterior tilting until you see the right lower pulmonary vein. And then in terms of the left lower, so left upper we talked about, in terms of the left lower pulmonary vein, so this one you can't really get from the apical 5. You go to a short axis, and then it's a modified short axis, so you'll have to go counterclockwise until you see the left atrial appendage on this side, and it will be close to it. The article had a nice way of telling how to acquire these images, and this table, I'm not going to talk about all of it, but I just highlighted 4 main points. So if you're trying to get the orifice and you find it difficult to visualize, try to go into apical city view and you'll be able to get to the orifice. And if you're trying to visualize the color signal, try to reduce the velocity. So the Nyquist limit, try to reduce it, and you'll have a better color signal. And the third one, and this is a very important one, so it matters where you sample the volume. So the location is important. They mentioned here 0.5 to 2 centimeters, but the optimal is about 1 centimeter. Because if you go deeper, you can have false positive or false negative waveforms. And the last one here is very important. So if you get the waveform and you see some changes with breathing, put the respirometer on, because you may be picking up a pericardial process going on. Okay. All right, physiology. Okay, so this is the bulk of the talk. So I just wanted here to show you the 4 phases, but of the waveform. But I'll go into details here now. So the first one is the A wave. So the A wave happens. Atrium contracts. At that point, the pressure inside the left atrium is higher than the pressure in the pulmonary veins, and this results in retrograde flow into the pulmonary vein. And because it's going away from the transducer, you get a waveform below the line. So it's a negative deflection. This is so it correlates with the left atrial pressure with the A wave of the left atrial pressure. So it mirrors it. So as one can imagine, it gets affected by the LV stiffness and the LA contractility, and things that will make it increased is if you have increased LV ADP, or if you have mitral stenosis because of the elevated pressures, and then in the left atrium, and then it's reduced by low if you have a low preload. Remember what we said about the right side affects the left side on the waveforms. So if you have a low preload, you get a lower A wave. The second wave is the S1. So S1 correlates with the initial part of the X descent on the LA waveform. So, and at that point is when you get the atrial relaxation, and this will with the atrial relaxation that promotes a movement of blood into the pulmonary veins. And it's affected by the ability of the left atrium to relax, and therefore it's also affected by the contractility of the left atrium. Things that will make it increased is if you have elevated LA contractility, and things that will make it smaller is if you have AFib, because you don't really have a proper mechanics of the left atrium. S2 is the second part of the S wave, and S2 has 2 main factors. So the propagation of the systolic ejection from the right side goes all the way to the left side, and it causes a pushing effect on the pulmonary veins and promotes filling. And so you get this positive waveform. And then the second reason is with ventricular contraction, the annulus gets pulled down. So that's another reason why the pulmonary veins get filled. And as you can see here, S2 is bigger than S1. And that's usually how it is. And it's a very important point to mention here is if you're trying to get the S to D ratio, you would take S2, not S1. So it is affected by the stroke volume of the right side. It's affected by the longitudinal function of the LV because the LV, as you know, it has three ways to contract: rotational, longitudinal, and horizontal. And then the last thing is the atrial compliance. So the things that will make it high is if you have high LV contractility, and it will be low if you have mitral regurgitation and it becomes blunted. And I'll show you examples of that later. The last waveform is the D wave, and D wave correlates with the Y descent in the left atrium, which is basically the atrial emptying, and makes sense. If the atrium empties, there's more movement into the pulmonary veins. It gets affected by LV relaxation because it's a diastolic event, and as well as the LV compliance. And so you can imagine things that will make it high include elevated left atrial pressure. Things that will make it smaller or blunted is impaired LV relaxation. And the last point here I wanted to say is if you look at these waveforms and the LA waveforms, they mirror each other. So when one is positive, the other one is negative. When one is negative, the other one is positive. Okay, for people who like flowchart. This is a printed slide, so you can print it, put it in your office, look at it, just for a simple reminder, like quick reminders. And it's from the article. It's a very nice, it's a summary of what I was just saying now. All right, some normal variations. So what I wanted to show you here, they look different. There are three different morphologies here in this slide, but they're all within normal. So these are normal variation. The typical one is this one, what you see up here. So S1 and S2 bigger than S1, and then you have the D wave and you have the A wave. This, however, is not uncommon. So you can have fusion, especially if you're doing transthoracic echo. You may not be able to see or delineate S1 from S2, and they look like one wave, and then the D wave and the A wave. And then this one, and this specifically, this can happen especially in people who are very young. You can have, because of the excellent recoil and the excellent elasticity of the left ventricle, of early filling, quick filling, the D wave. It looks like the E wave on the mitral inflow. So just like how you have a very large E wave, you can have a large D wave on the pulmonary veins. Typically, the SD ratio is more than 1 in normal. I've had a few examples from our echo lab. So
it's always good to show us.
Always, always. Yes. So this one shows you all 4 waves. It's a transthoracic echo. So it's a great one. So although sometimes it's really difficult to see all waves. So S1, S2, D, and A reverse. And this is a second example where you have only one S wave and a D wave and a reversed A wave. And then the last one, I thought this one is my favorite. So you can even see this relation between S1 and S2. So S1 is small, S2 is bigger, and then D wave, and then the A to reverse. Only 3 examples. Okay, so if you want to have a comprehensive assessment, it's there mentioned, but it's not really routinely done. But if you want to be comprehensive and want to do all the assessment, you can get all peaks of all waves, so the S wave, the D wave, and the A wave. You can get the duration of the A wave, and you can also get the deceleration time of the D wave, and then you can get the SD ratio as well. But this is beyond the topic. Hopefully someday somebody else will take over and talk about it in depth. It's non-exhaustive, just an introduction to the topic. Okay. So the effect of aging and the pulmonary vein Doppler profile. So 2 important things. So first of all, as you all know, the flow in the pulmonary vein is affected by the state of the myocardial relaxation. And the myocardial relaxation is strongly influenced by age. So as you go in young people, remember what I was saying about the recoil and the elasticity of the LV. So you can, in the beginning, you have a large D wave and a small A, or like a small A wave, and then they don't even rely on the atrial kick as much, so they can have a small A wave. not a big deal. But with aging, in the people in their third and fourth decade, the D wave gets shorter, and then you get the near equalization or even equalization of both waveforms. And then with aging, the D wave becomes even smaller than the S wave. Now remember, this is not diastolic dysfunction. This is just normal aging. So the LA pressure is not elevated like in diastolic dysfunction where it becomes large again. This is just normal aging with normal LA pressures. All right. Moving on to pathologies. So there are different diseases that affect the Doppler waveform. So valvular diseases like mitral regurgitation and mitral stenosis, and I'll show you examples of these. Myocardial disease, like systolic and diastolic dysfunction. Pericardial disease, constrictive and tamponade. Congenital heart disease can give you different waveforms, and rhythm and conduction disorders. And I'll show you an example of AFib later. First one, this is also from our Echo Lab. So the one on the left side is a patient who has, it's a TEE for a patient who has mitral regurgitation. And on the right side, you see a very nice waveform. So what you see here, actually, I'll tell you later. When talking about mitral regurgitation, there are a few things to talk about. So the timing. Remember, we said it's a systolic event. So the regurgitation just happens in systole, and therefore the S wave becomes, depending on the severity of the disease, it can be blunted, but it can also, when it becomes very severe, it becomes reversed and below the line. And however, it's not uncommon to see the early S1 first as a positive deflection, followed by the negative waveform of the of S2, and this happens specifically or especially in people who have myxomatous valve, mitral valve prolapse, because if you remember, the regurgitation doesn't really happen early. It happens a little bit more delayed. So the early part S1 is positive, and then when the regurgitation happens, and the reverse S2 becomes reversed. So the SR, or the reversed S2 or S wave in general, is a sensitive, it's not a sensitive but specific sign. So you may not see it because maybe you're at the jet location or direction because you're not sampling the right vein. But if you see it, it's specific. But if you don't see it, it doesn't mean that MR is not severe. And it can be false positive if you have deep sampling, or if you sample the posterior aspect of the left atrium, you can overestimate the MR severity. Okay. So as I was saying earlier, this is just a blunted S wave, but this one is reversed S wave during systole in patients who have severe mitral regurgitation. And I got this from a talk. It's an article that showed positive initial part of S1 followed by negative S2, and then a D wave in a patient who had myxomatous valve. So other than the reverse, the waveforms can be blunted. But very important point to mention, other than mitral regurgitation, there are so many other conditions that cause blunting of the S wave. So AFib will give you blunted S wave, elevated LV pressure, LV systolic dysfunction can also give you a blunted S wave. So if you see it, this becomes specifically important if you're assessing primary versus secondary MR. So if somebody has primary MR, it's more relevant. But if somebody has secondary MR and have blunted S wave, it's not always because of the MR. It may be because of the systolic dysfunction. Okay, now back to our case. So what I wanted to show you here is the initial positive. So this is a patient with severe MR. You initially have a positive S1 and then negative S2, and then you have the D wave. And then this person went on and had an intervention and look at the waveform. So the negative component of S wave became positive. So it tells you this person has excellent results. There's like, at least, if anything, the severe mitral regurgitation moved into very less. It's not as severe as it used to before, and from our Echo Lab as well. Okay, moving on, mitral stenosis. So mitral stenosis is very straightforward. Because of the narrow mitral valve, you have very low volume of movement of blood. So first of all, you have low or blunted waves to begin with. Second thing is because you have the diastole is long because the left atrium is trying to pump against the stenotic orifice. The D wave becomes longer, and you can see it here. So it's shorter and longer duration. And then the last piece is the A wave becomes longer because the elevation in the LA pressure. Okay, this is also reflected by the prolonged E wave across the mitral valve and the mitral valve inflow. Diastolic dysfunction, you guys all know about this, but just to make the point across, the E wave, as you see, as you progress in diastolic dysfunction, it becomes sharper and steeper. Same thing with the pulmonary vein D wave, it becomes longer and shorter in duration. This is a patient from the article. It shows you a patient who had initially a diastolic dysfunction here. And with time, and as his symptoms worsened, the E wave became longer and sharper and became shorter. And the same thing happened to the D wave. Okay, this is an example of atrial fibrillation. I thought this was cool, so I put it. First of all, you can see that it's irregular, but the other thing that's good to see, remember when I was talking about how the S wave is blunted? That's one thing. But then the other thing I wanted to show here is lack of A wave. There is no A wave. In this one, there's nothing below the line because there are no A waves in AFib. And then in this picture, I wanted to say two things. If you see this, do this. So this is a patient with pericardial disease. So if you see the variation with the inspiration, put on the respirometer. And then the last thing, I wanted to show you this one. Question, what do you think is going on? So it's okay, so there is a continuous flow in systole and diastole. This may help. And there is no A wave yet in ASD. This is another printed slide for people who like summaries. This is the one I just showed, ASD. It's good to look at when you have waveforms. And then that's it for me.